Good afternoon, everybody. Today I'm going to talk about my PhD, which is a bit different topic than the rest of the topics here because I'm studying schizophrenia and I focus on excitation, inhibition, imbalance, and use neurophysiological and neuroimaging markers of this disorder. So my name is Orsolya Lányi. I'm a psychologist and I work at the Department of Psychiatry and Psychotherapy. And my vision is to establish a neuroscience-based explanation for schizophrenia and spectrum disorders. And in order to reach that vision, my mission is to use neurophysiological and neuroimaging markers in schizophrenia. Here you can see my studies. I'm going to talk in more detail about the first two. But before I do that, let me introduce a bit the importance of this topic. So as you may know, schizophrenia is a severe psychiatric disorder which has shown an increase of prevalence in the last couple of decades. Schizophrenia can be characterized by three symptom domains, the positive, negative, and disorganized symptoms, which already shows you that how heterogeneous this disorder is. And this kind of heterogeneity is not very well explained by current diagnostic practice in psychiatry. So there is a huge challenge in psychiatric diagnosis. It is based on observation, which leads to bias and heterogeneity, and this is due to the fact that we don't understand the neurobiological background of these kind of disorders. So therefore, there is a need, an urgent need for a neuroscience-driven diagnostic framework for schizophrenia. One of the upcoming theories that can explain the symptoms of schizophrenia is the excitation-inhibition imbalance. So this kind of excitation-inhibition is a cortical balance of excitatory and inhibitory neurons. As you can see on the chart, this theory states that NMDA hypofunctions leads to this kind of excitation-inhibition imbalance, which is represented as on the network level as a disconnectivity, and that can lead to psychosis. The aim of my PhD is to study this kind of imbalance and find support for this imbalance using neuroimaging and neurophysiological methods. My first study, I used transcranial magnetic stimulation combined with electromyography to study this kind of imbalance. So how does this method look like? Transcranial magnetic stimulation is a non-invasive brain stimulation technique. And if the motor cortex is stimulated with TMS, then in the peripheral muscle, we can elicit a response, muscle response. This kind of response can be measured with electromyography. And depending on the strength of the stimulation and the time between two stimulation points, we can differentiate between excitatory and inhibitory responses. In my first study, I focused on 4 of these kind of excitatory and inhibitory responses in schizophrenia and compared them to healthy control population. Here you can see the methods, and we ended up with 36 articles in our meta-analysis. I'm presenting you today one of the results of the 4 paradigms. This is short interval intracortical inhibition. SICI, shortly, is a TMS-EMG paradigm that is a ratio number, basically, that expresses the amount of GABAergic inhibitory response. On the forest plot, we compared, or in our analysis, we compared schizophrenia patients to healthy control groups. Our FX measure was mean difference. And on the forest plot, you can see that those articles that are from 0 to left, they found increased inhibitory response in schizophrenia compared to healthy control group. Whereas on the other side of the forest plot, we can see those articles where they found reduced inhibitory response in schizophrenia. You can see that we found almost 14% inhibitory deficit in schizophrenia, which is a very robust result, I believe. And we also looked at how this response is associated with antipsychotic medication. We found that on a tendency level, that unmedicated patients have most reduced inhibitory response, and those patients who were treated with antipsychotics, they have a similar result to the healthy control group. I'm very excited to let you know that on this week, this article was published in a D1 journal. I'm going to move on to my second project where I used a different kind of meta-analysis or methodology in neuroscience research. This was a resting state fMRI, so functional magnetic resonance imaging study, where I focused on the cerebello-thalamocortical network in schizophrenia. So what is resting state functional magnetic resonance imaging, or fMRI? It allows us to study the functional connectivity or the temporal connectivity with different brain regions. This does not require a task while the patient is in the scanner, so it is quite convenient, and it allows us to reduce the signal-to-noise ratio. We focused on this analysis, the cerebello-thalamocortical network. This is the brain network, which has an important role in higher-level cognitive function. As you know, the thalamus not only acts as a relay station for sensory information processing, but also it has higher-level nuclei, which play an important role in cognitive functions. That is also true for the cerebellum, which is, I think, is a more surprising fact, that it does not have a role only in motor functions, but also in cognitive functions. So we focused on this network in schizophrenia. I used a neuroimaging meta-analysis methods, two statistical analyses. One of them is activation likelihood estimation, and I'm not going to go into much detail, but I would love to answer questions if you have questions about this. But this looks at the spatial convergence of different activation patterns. We separated the results for hypoconnectivity and hyperconnectivity, and today I'm going to show you only the thalamocortical connectivity results. On this plot, you can see those brain areas where the connectivity was reduced in schizophrenia with the thalamus. These brain regions are those brain regions that play important role in cognitive functions, such as the prefrontal cortex, the anterior cingulum, superior frontal gyrus, the cerebellum, and also intrathalamic connectivity. We found increased connectivity, so hyperconnectivity in schizophrenia, in totally different brain areas. These brain areas were more the somatomotor, somatosensory, and visual association areas. So we can say that hypoconnectivity, reduced connectivity in schizophrenia, is found in those brain regions that have a role in cognitive functions, and there is a hyperexcitability, hyperconnectivity in sensory brain regions. So to conclude, we can say that we found robust inhibitory, GABAergic inhibitory deficit in schizophrenia, and we found this with the TMS study. We also found that the thalamus has a pivotal role in the disconnectivity that is observed in the disorder. We found that this with the fMRI methodology. Both methodologies supported that there is a motor cortical hyperexcitability in the disorder, and both methodologies support the excitation inhibition theory or imbalance theory in schizophrenia. We believe that our research have some future or implications for future research. One of them is that the SICI, the TMS-EMG paradigm, should be evaluated by its specificity and sensitivity. We also find it important to evaluate the diagnostic specificity of this thalamocortical result. We believe the SICI in the future might be used for therapeutic response predictions, whereas this thalamocortical network can be used for a target for non-invasive brain stimulation techniques. I have some additional projects, which I'm just going to introduce briefly. From September, I'm going to spend 6 months in Yale School of Medicine collaborating with Dr. Albert Powers, and I'm going to use cutting-edge novel technologies in the field of computational psychiatry to further investigate early perceptual risk factors and the development of psychosis. I also have 2 additional publications, and I presented my work in several international conferences, and I also was a lecturer in an introductory statistics course for PhD students. So I thank you for your attention, and let me know if you have questions.
That was a great presentation. So my first question is about the SICI, about the mean difference. What is it measured in? Like milliseconds, seconds?
No, it's a ratio number. I'm gonna move to one of the plots that might help you better understand it. So basically in Psyche there are 2 stimulations given to the patient.
The TMS, right?
Yeah, and we measure the motor evoked potential. And Psyche is the ratio of the conditioned evoked potential to the unconditioned evoked potential. So the first stimulus is a conditioning stimulation given to the cortex. So, and this kind of ratio number expresses the amount of inhibition. So the higher the number, the smaller the inhibitory response is. So for example, a Psyche of 80 means a 20% inhibition. I hope this answers your question.
And about your second project, about the hyper and hypoconnectivity, you mentioned the different loci, but you had many patients. So what about the heterogeneity between the patients? Like, was it that all these patients had different loci that you just pulled together, or they were similar between them, similarities between them?
Just to clarify, are you interested in learning about how where in the brain the activations were, or the heterogeneity of the patient population?
Like the heterogeneity within the patient population that you studied, because you mentioned all of them, but were they similar between the patients, or they were just different patients, different loci?
Yeah, so basically we pulled together, we did different analysis, and we looked at those patients who have already developed psychosis and have a chronic schizophrenia diagnosis. We looked at first episode psychosis, and we looked at clinical high risk for psychosis. And I didn't show these results separately, but all of these patient populations have the same pattern of hyper and hypoconnectivity.
In the same regions?
Yeah.
Okay.
So this is a quite robust finding, and we believe that this could be state independent, so regardless on the stage the patient is in.
And just last one, I would like to say that as far as I know, like glutamate, we usually think it as an excitatory like molecule, but depending on the glutamate receptor, it could also act inhibitory. So basically, my question is, do you think that as the computational capacity increases, we could also look at this small difference inside the patients and check more robustly the responses and the...
Yeah, so what's very exciting, I think, is about neuroscience is that the brain can be studied on so many different levels. So we can study this kind of molecular level as well as network level. Yeah. So my research, I focus on more on the network level, but as I showed you in this introduction, there is indeed a lot of research, rodent, primate, molecular research that looks at the level of synapse. I'm looking more at the network level, but of course there is a lot of evidence and data on the synaptic level.
And when you go to Yale, it's going to be on the network level again?
Yes, on the network level, and we also, so there is a novel approach in the field of neuroscience called computational neuroscience, where we use different kind of computational and machine learning models to look at what goes behind these kind of brain activities and how these kind of brain activities work on an algorithmic level. I'm going to focus on that part.
That was great. Thank you.
Thank you.
Thank you, Orsolya. And I know the projects for years, but can you just give us an insight about the clinical usefulness of all that? Because possibly you did not touch that in depth, right? So, yeah. Because that would be, for us clinicians, very important.
Yeah. So I can say for Psyche that we believe that it could be used for therapeutic response prediction. So there is a new direction in therapy for psychiatric patients, that is brain stimulation, either invasive, so deep brain stimulation, or non-invasive, like transcranial magnetic stimulation. And we can look at this kind of Psyche measures before and after treatment. Psyche might be used also for supporting observational diagnostics with this kind of neurophysiological data. And for the thalamocortical network, we believe that in the future this could be used for targeting brain stimulation areas. So we have an ongoing clinical trial in the Department of Psychiatry by my supervisor where we stimulate the DLPFC and the cerebellum for schizophrenia patients. And maybe in the future it would be useful to look at individual networks of the patients and target the brain stimulation of those networks.
I really enjoyed it. Schizophrenia is, and this neuroscience is so hard to understand for me, but it would be so nice to have an understanding. And maybe just mind was tricking with me, but on the connectivity slides, where can you show the two brains where connectivity was higher than usual and less than usual? Can it be that, for example, these are worse connectivity slices, right? Reduced connectivity. Are they somehow can be connected with positive and negative symptoms? I mean, positive symptoms related psychological traits are affected on the brain areas where connectivity is worse, and higher connectivity means that I hallucinate Jesus every time with me.
Yeah, so with my research, I'm not able to answer this question with data, but I can tell you what I learned from the literature. So basically these brain areas in blue, so more of the prefrontal brain regions are associated with cognitive functions. So this could be connected to the negative symptoms of schizophrenia, where I can talk about a bit more about why the sensory regions and the thalamus has an important role in the psychotic symptoms. So basically there is a theory that the upcoming sensory information is not very well like reduced, or the thalamus does not acts as a relay station correctly, so lets through all the sensory noise, the ascending sensory noise, which like overfloods the sensory cortices. And without this kind of choosing which is important, which is salient, which is not, that can lead to hallucinatory symptoms. And this is supported by a bit more complex computational models. Mm-hmm. Yeah.
But also on the cortex, they are the sensory face recognition and those related cortical areas. So there, physically, the connections are different, or only the cortical pathways are just letting more signals there, and that's why they are overactive.
Yeah, so we didn't look at cortical networks, but there are different big brain networks, and we know that in schizophrenia, other brain networks are also affected. And there is also literature that looks at the white matter structure, so the structural connectivity in schizophrenia, and we know that from those results that indeed cortical connections are also aberrant. But here I just focused on a specific network of the, which looked at the thalamus and the ascending sensory information processing pathway.
Very interesting, thank you.
Yeah.
Yes, congratulations for this research. Is a little bit unusual, and I was very happy to listen to you. Your topic is well connected with neuroscience that you already said, but also with some topic of a philosopher who work in the cognitive science. I have a suggestion eventually to be in contact with one of them. I can help you if you want, because it's very interesting point. Yeah, from the philosopher part of view about this topic. Congratulations.
Thank you so much.
So it was I see that it's a really hard topic, and I'm terrible with neuro stuff, so I will just ask a really simple question, because as far as I know, schizophrenia has different severity levels. Is there a difference between these, for example, in the psyche, in the different schizophrenia severity groups, or in the papers everyone just said schizophrenia and this was the level?
Thank you for your question. I prepared a slide for you on the statistics, an extra slide, if you had like more detailed questions. But regarding the symptoms, for the psyche study, we did some exploratory analysis on the PANSS score, which is a positive and negative symptom scale that defines the different symptoms of the patients. And we did not find even a tendency level association with psyche. That's quite unfortunate, because in the different studies I read about that this might be associated with increased positive symptoms, but in our study we were not able to confirm this result. For this thalamocortical connectivity, it was not possible for us to statistically introduce this kind of variables. I did some subgroup analysis, but those were not very robust. So I think these are important questions for future research.
Thank you.
Thank you.
Let me just ask that whether these methods you looked at are standardized, or to what level they are standardized, because I observed in the first part of your presentation you included articles, one coming from 2002 and the latest one 2018. So didn't there a bias or difference exists because these methods are moving so fast and they are so different, might be different in some way? So are they standardized? So you are getting the same results from a paper which was written in 2002 and one which was written in 2018, 16 years later?
Thank you for this question. So for the TMS study, we were very strict about these protocols, and these protocols are standardized. So how and where you give the stimulation, what strength of the stimulation, how many milliseconds you have to wait between two stimulations, where in the finger do you measure the EMG. These are always surface electrodes. So these are very standardized, and I think because these kind of paradigms are used in neurology a bit more in the clinical practice as well, and psychiatry not really. So for the psyche study, I'm confident that it's rigorous. But for the fMRI study, less so. So here, just this plot shows you the plot on the top, that analyzing resting state fMRI data is a complex thing, and every study analyzes the data differently. That is why we believe that this kind of meta-analysis is very much needed, because fMRI studies are expensive. They are conducted with not many patients, and the pre-processing and the data processing pipelines differ. So with this meta-analysis, we wanted to confirm whether even with this kind of different methodologies, we can find spatial convergence of the activations found in the articles. So I hope that answered your question.
Do you personally use these methods in your practice or in your research groups? So do you have personal experience with these methods?
Yeah, we have fMRI and also DTI, so diffusion-weighted imaging that looks at white matter structural connectivity in the patients. We also work with EEG, and we have an ongoing clinical trial with transcranial magnetic stimulation, so yes.
Excellent, thank you.
Excellent presentation, and according to your message that psyche might have a potential in evaluating treatment efficacy. And if I remember correctly from my psychiatry practice, when you are introducing a new antipsychotic agent to a patient, you often have to wait for weeks when you are building up the dose to see that if this drug is effective for the patient or not. is there any hypothesis that maybe in changes in CK can precede the changes in the clinical signs, and maybe it can make faster the evaluation of the drug that has been introduced to the patient?
So I'm going to answer you from two different angles, because first, what I meant by therapeutic response prediction is mainly for magnetic stimulation or brain stimulation techniques. I don't know about whether it can be used for following up antipsychotic medication. The reason is that we also found in the article that this kind of CK is also associated with antipsychotic medication dose and type as well. So this should be further researched, how different kind of antipsychotics and also benzodiazepines affect this kind of measures. But maybe if future results supports that it's a good, it has a strong association or connection with, for example, benzodiazepines, then it might be used for that reason as well, or purpose. Yeah.
Thank you very much.
Thank you.
Just again a quick technical question. So in the first project, you did all the statistics everywhere. So there are two confounders that are really strong. One is that I asked earlier, the severity of the schizophrenia, and the other one that I can just quickly think of is the medication. Do you have or take or not take medications? Could you take these confounders into the models, or for now you just drop them?
No, indeed, I did all the statistical analysis myself for the fMRI study as well. And for the CK, I looked at everything that's possible. So we very thoroughly investigated different kind of confounders, either like clinical confounders, demographic, or methodological. And we found that CK was very robust and was not affected by either of these. So in the article, we also published data on age of the patients, diagnosis of the patient's medication status, and everything. The other two or other three measures that I didn't present today, these TMS-EMG paradigms, were not very robust, and they were indeed affected by different confounding factors.
Thank you.
Thank you.
Thank you very much. So my first question is that we can see that it's like a fingerprint of the disease, what we see on the fMRI data. And is it specific for schizophrenia, what we can see, or not? This one.
Yeah, so that's why I said or concluded that we should look at a more transdiagnostic comparison of different psychiatric disorders to study and further understand the specificity of this network disconnectivity. From the literature research I did, I have read that this kind of thalamocortical network is mostly highlighted in schizophrenia, but there should be future research that compares it, for example, to depression or other psychiatric conditions.
And do you think that there are psychometric tests which gain the foundation of these hypoconnectivity or hyperconnectivity or cortical differences? Is there any test that we can use in schizophrenia that shows difference from the normal population?
What kind of test?
Behavioral test or...
Yeah, so since the diagnosis in psychiatry is observational, so mostly in the clinical practice, different kind of interviews and cognitive tests are used. But there is, as far as I know, these are not specifically connected to these kind of network dysfunctions. But yes, it would be interesting to look at different kind of cognitive performance, task performance with this network disconnectivity.
Thank you.
Thank you.
So what is exactly seed? Seed to voxel and seed to seed?
Yeah, so that is the analysis method for the resting state of fMRI data. And seed-based analysis means that we choose a brain area, a location in the brain, And we look at the connectivity pattern, so basically the correlation of the temporal response of the Bolt signal between this specific brain region and any other voxel in the brain. Voxel is the unit of neuroimaging analysis.